Welcome, everyone. My name is Daria Camilli. I'm from the European Haemophilia Consortium, and on behalf of both EHC, which stands for European Haemophilia Consortium, and the ERN-EuroBloodNet, I'm glad to welcome you at the ERN-EuroBloodNet Topic on Focus on Willebrand Disease, a series of webinars for patient organizations and healthcare professionals that is coordinated by the ERN and the umbrella patient organization European Haemophilia Consortium, represented by the EHC Willebrand Disease Committee and patient representatives, among which the IPAC Baiba Ziemele. This educational program is created also in partnership with the EURORDIS-Rare Diseases Europe and supported by the members of the scientific committee, Professor Sophie Susen from France, Professor Jeroen Eikenboom from the Netherlands, and Professor Flora Peyvandi, present here today as the speaker with us from Italy. And the main objective of this program is to disseminate up-to-date knowledge among interested hematologists, gynecologists, internists, pediatricians, nurses, and other healthcare providers, and patients and patient organizations in the field of von Willebrand disease. Let me tell a few more words about the EHC. EHC is an international non-profit organization representing 48 national patient organizations for people with rare bleeding disorders from 27 member states of the European Union and most member states of the Council of Europe. We represent approximately 120,000 people diagnosed with rare bleeding conditions such as hemophilia, von Willebrand disease, and other extremely rare bleeding disorders across Europe. Among those, von Willebrand is considered as the most common bleeding disorder, affecting up to 1% of the general population. However, it is often neglected and overshadowed by hemophilia. This program aims to distinguish von Willebrand from hemophilia and focuses on the particularities of this bleeding disorder. In the framework of this program, we discuss very topical areas related to von Willebrand among patients and healthcare professionals and give visibility to the challenges of those living with this rare disease, including quality of life, access to treatment and care, medical services available in Europe, diagnosis, treatment options, and the overall patient journey through life. Before entering into details of this lecture, I would like to share some home rules and give you more information. Since I said we see some students present here, it is important to mention that the program is accredited by the European Body of Accreditation in Hematology with continuing medical educational points. Each session is 1 credit, and you can get 13 credits for the full program. Or require only 1 credited association to the lecture you have assisted. How to get those points? Please pay attention that you have inserted your full name and surname in the Zoom platform, and also please at the end of this session you're going to receive a survey, satisfaction questionnaire, so it is mandatory to answer the survey in order to get the accreditation, because this is a way we track your presence at the program. So in the nutshell, name in the platform is important, and please answer the questionnaire which you will receive at the end of the session. When the program will be finished, we will contact you with the instructions how to get the credits and how many you get. So some more technical information. This session is recorded because this is implemented in the future, will be in the learning environment of both ERN and the EHC website, YouTube, and other learning platforms. So if you do not feel comfortable about that, please put your camera off. Also, please mute your microphones during the speech of the speakers. If you have any questions, please drop them in the chat and we will address them after the presentation of both speakers. Then I think we can move to the session of today. Today's session is number 7 already, and it is devoted to the topic, which is surgery in patients with von Willebrand disease. And with great pleasure, I introduce you to the speakers. So we have Flora Peyvandi, who is the professor of internal medicine at the University of Milan, Italy. She's also the director of the Angelo Bianchi Bonomi Haemophilia and Thrombosis Center of the Milan Policlinic Hospital in Italy. She's currently the president of the International Society of Thrombosis and Hemostasis and past president of the executive committee of the European Association for Haemophilia and Allied Disorders. Professor Peyvandi also serves as an advisor on the European Medicines Agency and on the Technical Health Committee of the Italian Ministry of Health. And as a patient representative today, we have Julia Rauscher from Austria. She works as a self-employed orthopedic shoemaker. Julia was diagnosed with von Willebrand disease type 2N at the age of 25 without any family history of bleeding disorders. She's also a member of the Austrian Haemophilia Society, where she volunteers as a women's secretary. She has been the member of the EHC von Willebrand Committee since it was founded in 2020. And currently she occupies the position of co-chair of the EHC von Willebrand Committee. And with this, I pass the floor to Julia to start the presentation.
Hello, welcome everybody. It's really amazing that so many people are joining, and I hope you really enjoy our webinar. So, my name is Julia Rauscher. I'm from Austria, and as Daria already mentioned, I'm a patient with VWD type 2N. Like in many cases, my diagnosis came rather late at the age of 25, as there was no family history. Back then, I had an emergency surgery due to a ruptured ovarian cyst, which bled into my abdomen. And after surgery, doctors recommended that I get my blood clotting checked. At first, I was misdiagnosed with hemophilia A, and the hematologist back then told me that I should better not give birth to children. Later on, it turned out that I have von Willebrand disease, which explained many previous events that I had, bleeding events I had throughout my life, such as heavy nosebleeds, menorrhagia, and joint bleeds. Although many of those symptoms should have been an alarm signal, no doctor ever thought to investigate. Since my diagnosis, I only receive factor treatment on demand. So I have no home treatment yet, not to talk about long-term prophylaxis. Just recently, I needed to go to the emergency room as I had another ruptured ovarian cyst. The doctor in the hospital did not recognize the seriousness of the situation and didn't listen as I tried to explain that I have VWD and it would be urgent to get factor treatment to stop the bleeding. In the end, I had to take matters into my own hands. I called the emergency number of my hemophilia treatment center, which in turn called my hospital, explained the seriousness of the situation and helped me get factor treatment immediately. With my own patient story, I would like to draw attention to how important an early and correct diagnosis is, and that comprehensive care is essential to make sure every VWD patient gets proper treatment. It should be considered more often to put VWD patients besides type 3 on long-term prophylaxis or at least on demand with home treatment, as many bleeds could be prevented in advance and the need of some surgeries could be avoided. Every surgery needs a medical team that is aware of the complications that might occur during procedures. That's why comprehensive care is so important. And we as patients need to educate ourselves as best as we can to eliminate every lack of knowledge or attention of healthcare professionals if needed. So now I want to give the floor to Professor Flora Peyvandi, who will tell us more about VWD, an overview of symptoms, diagnosis, and when it comes to surgery, so prior and post-surgery, what to take care of. So happy to have you, Flora.
Thank you very much, Julia. Let me to thank European Blood Network and also ERC, and this combination together did come over with few sessions, as you heard, and today we are focusing on von Willebrand and especially on the surgery and also on women. I tried to put some of the slides together and I would like to share the slides with you. Hope you can see all.
Yes, it works.
But here is not changing my slide. Let me see. Okay, let me do it again. I hope this time will allow me to share it. Yes, now
Yes, it works.
possible to change it. Thank you. So these are my conflict of interest as an advisor and participation in the educational meeting or symposium of the different companies. What we thought today, it would be good to share and discuss a little bit on von Willebrand role. And I want to explain a little bit, especially for patients and for the student, what is the role of hemostasis, what is the role of von Willebrand hemostasis and this dual work of von Willebrand, and how it's difficult to make the diagnosis, and having a diagnosis, especially when the resources is not really perfect in a labs and there is no specific and specialized lab, and how that could impact on the treatment and management of the patients. And we're going to look together what is the situation with the surgery, how we have to behave, and what is the international guidelines like now, and how we have to behave in the delivery. So let's start with von Willebrand factor, which is the biggest glycoprotein in the circulation, in the human circulation, and it's extremely complicated. However, it's called only one with one name of von Willebrand. This is a multi-domain factor, and it's doing a lot of stuff. But you have to learn two things, which is important. The first part, this molecule, as you can see here, where it is loosely coiled, and during the normal condition or low shear stress is not activated and is just moving in the circulation. However, if there is any kind of challenge and the endothelial cells, they're getting activated, then the von Willebrand change completely its phase and getting activated because the collagen is getting exposed and the conformational form of the von Willebrand factor is getting changed and getting unfolded, and the sites of the binding for platelet and Adams 13 is getting activated. And that stage is starting the platelet that are having there, and you can see here in the picture, and is the first step of every hemostasis process. So you have the formation of the first fibrin clot or plug. But this fibrin clot is not really stable. You need something, which is in this case, the clotting factor and factor 8 to get it active. A very firm type of coagulation. So this is the role of von Willebrand factor in primary hemostasis. However, there is also another role of von Willebrand factor, which is binding non-covalently to factor 8 and is preventing the degradation of von Willebrand of factor 8 in the circulation. So that means if von Willebrand factor is not around, factor 8 is getting degraded much easier. And that is giving the role to von Willebrand factor to participate in the second part, which is the proper coagulation. So based on that, the first question that you have to think, if I'm missing this factor, what's going to happen to me as a patient and how I have to have the diagnosis? Since this factor is participating in the primary hemostasis and secondary hemostasis, as we heard, the primary hemostasis is more associated to the mucosal type of bleeding. As Julia was reporting, epistaxis, gum bleeding, menorrhagia, these are kind of mucosal bleeding that is important in von Willebrand disorders. But there is also some of the bleeding similar to hemophilia, like hemarthrosis in joint, the bleeding in the joint, and the bleeding in a muscle. Here is a big table, which I don't want to go through. I don't have no intention to go through the details, but I just want to show you how different is the diagnosis of von Willebrand factor compared to hemophilia. In hemophilia, you only measure factor VIII, and based on the amount of factor VIII, you decide the level of the severity of hemophilia. However, in von Willebrand factor, there are three big types. Type 1 and 3, they are quantitative disorder. In type 1 is a partial quantitative disorder, and in type 3, you have a complete deficiency of von Willebrand factor. In type 2, that's a qualitative disorder, means the protein is there, but this protein is not functional, and there is several subtypes which requires more specialized assay, which is not available everywhere in every lab in the world. And that's the reason with von Willebrand factor antigen activity and factor VIII, you are able to make the first diagnosis of type 1, 2, and 3. But for all other type of subtypes, you need to go to specialized center where they are able to add several more assays to look on what is the subtype of von Willebrand disorders. For example, Julia was mentioning that she's affected with type 2N. And now, what I thought it would be good for you to know, how is important to have a correct diagnosis in your patients. For example, from first, I would say phenotype, you might think that type 2B is similar to platelet top of von Willebrand disorder. But if you make the correct diagnosis, these two types are completely different. One is due to the gene mutation on von Willebrand, the other one on platelet. And the treatment of type 2B is the von Willebrand concentrate. However, in platelet type von Willebrand disorder, you need the infusion of platelets. In type 2B, you might want to avoid the use of the DDAVP, but you can use the DDAVP in other type of 2A or 2M, and that difference is extremely important as well. Type 2N and hemophilia should not be misdiagnosed for several reasons: type of treatment and counseling, genetic counseling. The transmission of first type is autosomal, and the second one is X-linked. And you need to make a correct diagnosis for counseling, but also for the treatment, which in type 2, you use von Willebrand concentrate, and in hemophilia, you use factor VIII concentrate. And in type 1C, DDAVP may not be the proper treatment. But who are and which classes of von Willebrand require genetic counseling, and especially prenatal diagnosis? That needs to be reserved in those families where there is one affected child, or there is a gene mutation that is associated highly with the birth of a child affected with a severe type of disorders. So the quality of life of all our patients with von Willebrand disorder could significantly change if the diagnosis is not accurate. Julia reported it took 24 years to make a diagnosis and to make a correct treatment and understanding what is happening. And that's the reason why we need educationally to work and changing the quality of the diagnosis of our patient by improvement of the phenotype and the genotype labs in the world. In a second part of my talk, I want to focus on guideline and the indication of the guideline for the treatment of patients affected with von Willebrand disorders during the surgery and during the delivery. First of all, it's very important to understand, as I said, the person who is coming to our observation, what type of von Willebrand factor is there, the severity of the disorder, whether there is any presence of inhibitor, and what type of treatment should be used in this patient, with which dosage and frequency, and which is the patient who require regular prophylaxis. And when you are organizing a surgery, you need to make sure you are minimizing the bleeding episode in your patients and maintaining the hemostatic factor 8 and von Willebrand factor more than 50 international units for reducing the risk of the bleeding during the surgery, but until that healing is complete. And that is very much different from minor surgery to major surgery. In some surgery, maybe you need only 1 day, in some of them 3 days, and some of them more than a week. So the guideline is just proposing us to increase von Willebrand factor activity more than 50 international units with desmopressin or factor concentrate, with the addition of antifibrinolytic therapy, which is tranexamic acid, and is making a suggestion to give the tranexamic acid in patients with type 1. As I said, these patients are having minor quantitative defect with basal von Willebrand factor activity, which you want to keep it more than 30 international units for reducing, and especially if the patient is having more than 30 by basal level, with tranexamic acid is enough to cover some of the minor surgery. And there are some remarks I think is important for the physician to read carefully these remarks, that individualized therapy should be done for every patient, because every patient has his own history about what is the activity, what is the subtype, and how I'm going to keep the levels more than 50, as I said, and whether there is a need or not need of tranexamic acid, which I think it would be very important before this surgery to add. And patients with type 3 von Willebrand require the concentrate of von Willebrand factor to achieve an important and significant increase of von Willebrand activity. Now, if the surgery is an acute surgery due to trauma, you cannot use recombinant product alone, but you have to add also factor 8 if the level of factors are 0. But if you can plan, you can use von Willebrand factor and wait for a few hours, your level of factor 8 could increase. So then it's very important also what type of the product you can use based on the emergency of the treatment. Be careful about when you are actually having a patient with type 3, do not use DDAVP, because there is a risk that you have actually you don't have increased level of von Willebrand factor, because what with DDAVP you want to have at least to increase 3 times more the level from the basic level. And patients with type 2, type 2B, require treatment with the concentrates, and they are not benefiting from desmopressin. And there should be some kind of attention to thrombosis, especially if you are using the complex of factor 8 and von Willebrand factor, and you want to keep the level of von Willebrand over 50 for several days, you have to pay attention, not making an accumulation of factor 8 and exceeding over 150. And if that's the case, you have to think about whether you want to use the pure von Willebrand factor or if there is a need of addition of any also anticoagulant therapy. In dental procedure, also consider the use of the local hemostatic measures. What about the major surgery? The international guideline is suggesting that we have to target both factor 8 and von Willebrand factor with more than 50 international units for at least 3 days. As I said, in some patients, the major surgery, orthopedic surgery, or neurological surgery is more than 7 days or 10 days. keep both trough level more than 50 international units for at least 3 days after the surgery, as indicated by the clinician. Instead of choosing one single factor, you have to make sure that both is increased. The specific target level should be individualized, as I mentioned before, and the duration of intervention, as I said, can vary for a specific type of surgeons. There is very important information coming from this slide for anesthesiologists and also for those women that need the spinal epidural type of treatment before delivery for resolving the pain and for pain relief during the labor. Because, you know, usually, if they are not expert, they are afraid of using, and the women, they have terrible pain and they don't want to treat them. But the suggestion is to target von Willebrand factor level between 50 to 150 international units, and individual, again, risk assessment should be performed. And it's very important for the clinicians to check with the patients the third trimester, the level of factor VIII and von Willebrand factor, and decide how to move. Von Willebrand factor activity should be maintained over 50 international units when there is epidural is in place, and at least please remember for 6 hours after removal of the catheter. The decision regarding the anesthesia and delivery should be made in the context of the multidisciplinary discussion which hematologists, anesthesiologists, gynecologists, or obstetric, they are working together deciding how to manage the patient. And the discussion should take place in advance of the patient due date. You don't want to have at the time of the delivery when everything is a little bit more, I would say, emotional, or a little bit of a stress is there to decide how you want to treat the patient. You want to plan everything before. At least that's not an emergency treatment. Patients should be assessed for thrombotic risk post-delivery, as I said, and if the level of factor VIII is getting over 150, you might look for the prophylaxis. So all over, I would say for pregnancy in women with von Willebrand disorders, please make sure you are in a type of von Willebrand that there is or there is no chance to increase the level by physiological rise of von Willebrand factor and factor VIII, because women in pregnancy, they are showing increase of the von Willebrand factor and factor VIII level. However, for example, that is not happening in type 3, but could happen in type 1. And that's the reason why it's important in the third trimester to have the multidisciplinary team and decide together whether this woman do need the treatment, prophylaxis, or whatever type of treatment, or the amount of the level is enough. And please remember, after delivery, the level is getting down. And that's the reason why you want to make sure these women are not at risk of post-delivery bleeding, which could happen in the first 24 hours and could be massive type of bleeding, is a primary blood loss, more than 1 liter within 24 hours, or could happen as a secondary PPH with a heavier bleeding between 24 hours to 6 weeks. So that's the reason why the level of the factors in these women should be absolutely assured. There is some restriction in the use of the DDAVP in the pregnancy for fetal hyponatremia, and also the side effect that could be with the DDAVP because it's interacting with oxytocin receptor and could promote the uterine contraction. And DDAVP is practiced in the UK, both in pregnancy and delivery, and in some countries in the world has been used, But if you are using, please make sure that you are not using more than 2-3 times because of the hyponatremia and also because the responses is getting much less. In the last part of my presentation, few minutes, I want to share some of the clinical case with you and how only von Willebrand is not there, because fortunately we have our patients with bleeding disorder that could get all other type of concomitant disorders, and we have to pay attention on that. This patient is in Milan, 47 years, with a family history of inherited bleeding disorder, type 3 von Willebrand disorder, with level of antigen of von Willebrand less than 3%, RICOF activity of von Willebrand less than 6%, and factor VIII of about 1%. So that's a severe case of von Willebrand disorders with a BMI of 19.5. This person has actually systemic lupus erythematosus with a significant skin involvement, treated daily with prednisone, psoriasis, gastroesophageal reflux, osteoporosis, and fibromyalgia syndrome. That means lots of pain. She had HCV, hepatitis C in the past, and was active chronic HCV, which has been eradicated, fortunately, but has mild steatosis with a stiffness of 4.4 FibroScan. Her clinical manifestations started when she was a kid with epistaxis, gum bleeding, and frequent bruising. Menorrhagia, which led to severe anemia and blood transfusion, muscle and joint bleeding requiring episodic treatment containing factor VIII and von Willebrand factor. She did suffer from GI bleeding, which led to anemia and blood transfusion, and she had 2 pregnancies with 2 cesarean sections, dental extraction, and endoscopic procedure with factor VIII and von Willebrand factor. This patient at the beginning was not on prophylaxis. She was not accepting the concept to start the prophylaxis when she was much younger. And when it started to have multiple GI bleeding, which was showing the angiodysplastic lesion. As you know, when there is no von Willebrand factor, there is a formation of this small vessel. And this vessel, with the elderly age, start to bleed. And that's the reason why prophylaxis is becoming extremely important. And at that stage, we were insisting that she starts the prophylactic treatment in order to get rid of this GI bleeding. So the acute bleeding episode was treated with a red blood cell transfusion, the use of iron because she was getting anemic and her quality of life was much lower, with folic acid. And as I said at the beginning, she was using factor VIII von Willebrand factor plasma-derived component maintaining factor VIII over 50 and von Willebrand factor over 30 international unit at the time of the bleeding, at least for 7 days. As a prophylactic regimen, we started with 50 international unit at beginning of the prophylaxis, 3 times a week. And that really helped a lot. After a long time, I have to say, you are not going to see the results of prophylaxis immediately because that should interfere with your angiogenesis. So the episode of GI bleeding was requiring 4 blood cell transfusion and long-term, as I said, of prophylaxis. After 2 years of 50 international unit, we just reduced the prophylaxis to twice a week, and then a little bit less with 40 international unit twice a week. And the patient fortunately stopped to have the GI bleeding in the last 5 years and did not receive any iron therapy. And right now, she has severe arthropathies, which is making to think why we did not push 40 years ago to start with the prophylaxis. And that's the message I want to leave. We do not have to wait really. And as soon as the patient is having important bleeding, I think is important to start the prophylaxis, especially in the severe cases. So the final conclusion is prophylaxis is important for type 3, no doubt. No evidence-based recommendation could be done in which time is the best time and when we have to stop. Right now, I think severe cases should start as soon as possible. And what is important to have an easier way of prophylaxis, and I hope soon there would be much easier way of prophylaxis for our patients. And starting with 30 to 50 international unit twice or 3 times a week after the first episode of the GI bleeding is definitely proposed. I would not wait for the GI bleeding, but I think since not all your patients are on the prophylaxis, please keep an eye on them. And for those that are less than 5%, definitely the prophylaxis is highly recommended. This is more or less what I wanted to share with you, and I'm happy to get any question, doubt, and discussion. I leave it to you, Daria.
Thank you so much. Thank you, Professor, and Julia as well. We haven't received any questions so far in the chat, but if anyone wants to raise a hand and ask a question just out loud, it's also fine.
I actually would have a question.
Go ahead.
As you talked about pregnancy, and you said that it would be very good to do the screening and check during the whole pregnancy where the levels are. So if you are pregnant, what would you recommend to, how often would you check your levels if they rise or not? So like in my case, in type 2N, would you say like every 3 months go and check the levels, or every month? Or
yeah, I think actually the first period of the 3 months is important because it's an implantation. And on that, we still, I think we need good data, but I would say, I would love to see that the level are not less than 30. I would prefer 50 for the fetus implantation and avoiding any type of abortion. And for the last part is extremely important, as I said, before the delivery to make sure what is the level of the factor. I think monthly would be fantastic, but every 3 months is enough as well.
And if another question for that, so in type 2N, there is like von Willebrand's is quite normal in my case. It's only the factor VIII who is lowered. So would you recommend then, if you need factor replacement, taking the recombinant therapy then, so factor VIII and von Willebrand's?
Yes.
Or yeah.
I mean, depends on what is available in your country. You do not want to have accumulation of factor VIII, and you don't need factor VIII, as you said, because it's a problem of the binding. And probably making a pure von Willebrand factor is much easier for you. I would say if the level is less than 50, I would start with, if you have von Willebrand factor, I would get the von Willebrand and check factor VIII, the level, and make sure what is the level of factor VIII as well.
Thank you so much. I have a comment from Baiba, and I have a question coming from the chat. A comment is as follows, that if this is so complex for planned surgery, I can only imagine the stress and confusion doctors and patients go through when in emergency situation and lack of health data and or knowledge. Fair enough, I believe. And we have a question to Professor Peyvandi. What would be the recommended dose for long-term prophylaxis?
I think 30 to 50 international unit based on what you want to keep. Ideally, I would prefer to have more than 50, but at least 30%. So it depends on what is the level of the factor that you have. So I would say between 30 to 50, twice or 3 times a week.
Thank you so much. No other questions so far. Anyone wants to raise a hand with a question?
Yeah, just I would like to, I am from India. So actually, I would like to know the management of pregnant women in van Willebrand disease. Generally, what we do before delivery, as the protocol, 50 units per kg body weight, and we manage, but there is some, we don't know exactly how long we should maintain prophylaxis, whether it is in terms of weeks or a month. Because in a developing country like us, getting the treatment product is challenging, and we will use, and we generally get the intermediate purity factor, not specific. So how to manage such situation? How long, whether you advise 1 month or 3 weeks prophylaxis, so that it should not go into PPH?
Yes, I think as I showed, depends on what type of product. You said you are making the usage of intermediate purity factor 8 von Willebrand factor. That means more and less you would have 1:1 about factor 8 and von Willebrand factor, and you keep the level about 50% before the delivery. I would think 1 month or 6 weeks is a time that I would keep it, because you are in this case avoiding the primary and secondary PPH.
Okay. Okay, thank you.
You're welcome.
Thank you so much. Any other questions?
Hi, yes, Daria, I hope you can hear me well. I'm Katarina from Romania, and I do have a question for Dr. Flora. I am diagnosed with 2B von Willebrand. I have 35 years old. I had a normal life with issues only on my period and dental extraction. Unfortunately, I had a surgery 1 month ago with difficulties in terms of bleeding. But till then, normal life, also no bleeding on colonoscopy. And I was wondering if with 2B, it's possible to to have a normal life as could be called for the future.
That's a good point. Actually, the 2B could be very much heterogeneous. I think in 2B is very important the level of the factors, the level of the number of the platelets, and keep an eye when you said you are 38. Is that correct?
35 years old.
And of course, you are not in prophylaxis.
No, I am not. I had a normal life only with dental surgeries and heavy menstrual bleeding. I discovered 2 years ago by coincidence.
Sure. I think for your surgery, of course, you need the treatment, appropriate treatment, and do not use the DPAVP, as you very well know, just the concentrate. And for the rest of your menstrual bleeding, it's very important to talk with the gynecologist whether there is a case to use the pill and to see whether the level of the factors could increase, or the menstruation could be controlled with that one, or with the antifibrinolytic. But you had already the surgery, and after surgery, how is the situation of the bleeding?
Unfortunately, I'm from European country, Romania, and it was my first surgery, and I had a malpractice. It was difficult. I was bleeding for more than 6 weeks, but I finally was able to find a good hematologist who helped me with the Vilate, very tough, let's say, 2 weeks with the factor 2 times per day. And now I'm good, but was my first experience, and it was a very quite traumatic for me. And my question is, the life it will be as it was before, or because I had this surgery, I will start having difficulties in terms of.
I'm sorry that you had such a really negative experience, but it's not working. That once you have your diagnosis and if it's managed, your experience was terrible, and it would not be like that, because Villate has been used twice a day during the acute, treatment of the surgery, and that's a good product. And if you still have the problem of menorrhagia, anemia, low ferritin level, please consult a gynecologist for deciding whether it's a case to use the hormonal therapy or you need to be treated properly. This is my recommendation to you.
Thank you so much.
You're welcome.
I have questions from the chat. We have a question to Professor Peyvandi. How should patients with von Willebrand disease manage their condition in day-to-day life, especially in terms of diet, exercise, and preventing bleeding?
I think as every other person in the life, we need to have a healthy life. So we have to eat well and we have to make exercise. But if you are a von Willebrand factor with severe reduction of the factors, you want to make sure that the level of the factor is enough for the type of the activity that you are doing. In other words, you do not have to damage yourself to do such activity if you are not covered or you do not have the prophylaxis. Once you have the prophylaxis, your level of factor is enough to do almost the activity. Of course, you cannot jump from 50 meters because that is also damage, there is a damage also for the normal person. So I would say with the prophylaxis, you can do whatever you want.
Thank you so much. I have a question from the chat for Julia. What can patients do in an emergency situation in order to get access to the correct treatment as quick as possible, bearing in mind that health professionals often do not know about our disease? Any advice? And the same question to Professor. So basically, in the end, to both of you.
I will go first then. Yeah, it's difficult. Sadly, like I just had the experience, it's really mandatory that you as a patient try to educate yourself as much as you can and make as much pressure as you can if you get into the situation that the doctor does not take you serious. And like in my case, we have in Austria, we have an emergency number of the biggest HTC in Vienna, which is reachable 24 hours, 7 days. So I have this number on my phone, and that's what I did. I called that number, and the hematologist there called my HTC and told them what to do because they wouldn't, the gynecologist didn't want to listen to me. And this situation, I tried to explain to the gynecologist that it's no pity if it doesn't know more about von Willebrand. He said he knows it, but he didn't know, doesn't have any specific education. And I said, it's no pity if you don't know, but I have a number, I have somebody you can call, and you should call this person. But he denied again because he thought he was a bit wiser than me. So just try to insist to get your treatment. If you're in the lucky position to have long-term prophylaxis, usually it should not be big of a problem. If you have some kind of treatment at home, you could at least somehow prevent some bleeds. I didn't have that till now, but we'll get some factor for storing it at home if such a case occurs again, and I can just go to my general practitioner and tell him to infuse me the factor treatment, as I cannot do myself. But yeah, educate yourself and keep telling what's correct, and don't let yourself be drawn down by any healthcare professional who is not well educated in a bleeding disorder.
Unfortunately, it happens, and we witnessed this situation that happened to Julia because we were at the EHC von Willebrand Disease Committee. We were constantly in touch at the time of that situation, and we were very relieved when we finally got the news from Julia that she managed to advocate for herself and to get her treatment. We were really worried. So thank you, Julia, for sharing your story. And the same question was for Professor Peyvandi.
Yeah, I think actually I agree with whatever Julia said. What, as a physician, I want to tell you, in emergency, lots of doctors, they don't know about the rare disorders. And that's the reason I think the doctors should learn from you. And that's the reason why what Julia was saying is very important. You need to be very much educated about your type of the bleeding, your diagnosis and your treatment. But you can even think, this is not fair, this is not my job. It's true. The physician, they have to know it, but at least if something happening, you know what should be done. And second point I think is important is to treat yourself. To be able to treat yourself means every time when there is acute bleeding, at least the first shot of the bleeding, you can first shot of infusion, you can do it immediately. So that are two things I would recommend. For those of you who are on recombinant product, make sure that the level of factor VIII, because as I said, von Willebrand factor is for prophylaxis, and when you are on the regular prophylaxis with the recombinant or pure von Willebrand factor, the level of factor is jumped already up. But if you are not on prophylaxis and you have only von Willebrand factor, you have to make sure that you are adding factor VIII in the emergency with von Willebrand factor. And these are the three things that is important, and antifibrinolytic, of course, Tranix, and this type of actions is improving a lot your situation during the acute state. And knowing who is the reference center and immediately to be in touch with the physician. For example, my center is a 24-hour, 7 days, and our patients have the numbers, they call, and they always know there is a physician. I hope that most of the centers, they can give you this service, but if they are not, all the centers, doesn't matter. There are centers that they are doing. You have to find the closest for the acute treatment, but then be in touch with the reference center.
Thank you so much. And there is another question for you, I believe. How do you decide for treatment during surgeries if von Willebrand disease type or severity is not known? Which would be the safe way, factor or DDAVP or tranexamic acid?
Okay, if I don't know what is the subtypes, I should measure it. If I'm in a place that I cannot measure it, then I would use and if there is an acute bleeding, I want to make sure that the news is correct, because some documentation should be there. This is from Willebrand. And if I don't have anything, I would use something which is factor VIII and von Willebrand factor.
Thank you so much. No other questions so far.
I would have one more if I
Yes.
am allowed to. It's not something on surgery, but as you mentioned, and as we just recently had a roundtable where this also was a topic, that when it comes to long-term prophylaxis, as we see it in hemophilia, one of the main goals is that if you have hemophilia, that you never ever get a joint bleed. And if you ever had one, that's the latest point you would get any sort of prophylaxis. But in von Willebrand's, it's like in my case, I had a joint bleed once, 12 years ago before I was diagnosed, so it was not treated at all. I have major arthrosis now, and I'm still wondering if there are microbleeds or not. Nobody can tell me. And still, my hematologist says, we're not sure if we can put you on prophylaxis because of, I mean, there were some other things as well, but the joint bleed itself was no alarm like you will get it.
if I have a patient with the start of the joint bleeding and synovitis, I would start prophylaxis, and I don't want to wait to get to that. As I told you, now in type 3 von Willebrand factor, who are 45, 40, 50 years, more than 40 years, most of them, we can see that they have arthropathies. And I don't think we need to wait. That's the reason I think for von Willebrand, we are behind the correct and optimal treatment. So for a case of 2N, of course, you have to make sure not having accumulation. And that's the reason why your physician were afraid of not making accumulation for factor 8. But if you have a pure von Willebrand factor and you can be treated, with the ultrasound evaluation, there is a sign of the suffer of the joint, I think I would have started in my patient.
Okay, I have a comment coming from Baiba that she was told after USG, sorry, I don't know myself, what is this? Minor synovitis. It's ultrasound.
Yeah.
Okay, minor synovitis is normal for anyone my age, not necessarily coming from microbleeds in my joints.
I love you, Baiba, because your questions are always very fascinating. First of all, you're young. If you want to believe or not, Baiba, you are still young, and I don't think your joint should be really damaged. And it's true, all of us, we would have at some point synovitis. My knee actually is painful since 2-3 weeks, and I'm not having a bleeding disorder, but I'm getting older and I feel it. So I think it's true that every alteration in the joint should not be considered a bleeding episode. However, in a patient with bleeding disorders and von Willebrand, it should be considered that the risk of having a minor bleeding is much higher. Now, I think the ultrasound evaluation and prophylaxis could be recommended in patients with bleeding disorders.
Thank you. While we're waiting for probably some other questions to arrive, last ones, if possible, because we need to let Professor go. I just want to remind everyone that this program is with regular webinars, and the next one we will have on October 17, which will be devoted to the topic Women Bleed Too. So please register and come. We will have a trio of speakers. We will have a patient, a clinician, and we also have invited a nurse to join that conversation. Please register, join. It will be interesting, I'm sure. Also, I want to remind everyone that those of you who want to get accreditation points, please don't forget to fill out the satisfaction questionnaire that you will receive after this webinar. And I see the question that arrived. From Katie. She's from the EHC von Willebrand Disease Committee. She said that her daughter, type 2N patient, has the privilege that she's having prophylaxis during her period. Why do you think it is so hard for von Willebrand disease patients with severe bleeds to get prophylaxis? That's a
good point. I think because it's an education, and as I said, we are behind. The women's voice was not heard as much as it has to. And it has not been taught that the women are having triggers, and that's bleeding every month. That's a period, and that period is associated with a large number of bleed and amount of the bleed and the days of the bleed. So it's not normal to have a woman with 10 to 14 days of bleeding. The quality of life of this person is low in that case. So I think the voice of the women and also our understanding of what we should achieve scientifically, which level is the optimal level, and I hope in the future also easiness of the treatment will make us to choose the best therapeutical approach in terms of the prophylaxis in the future for making in a very safe condition and trying to bring the condition of our women to a normal life of a woman without any any problem. Now, with what we have available, I think hormonal therapy, DDAVP, antifibrinolytic, these are the easiest way of treatment. And if all of these they are not working, I think one shot of treatment the first day of the treatment of the period could really help increasing, or you know, as a woman, when your period is arriving, you can just decide to treat yourself before. As I said, depends to the level of the factors that you have, and the therapeutical strategy depends to your gynecologist if they want to control it with the pills or they want to do it with the AVP. But antifibrinolytic you can use. But if none of these methods are working, then we can think about surgery. But I would prefer to really use prophylaxis accurately. And my hope would be as soon as possible to have non-intravenous injection, subcutaneous, with a long distance, once a month, and something like that. That would be fantastic. We are all working for bringing that to the market.
Thank you. We have a lot of thank you messages on the chat.
Thank you very much. It was really great to see you all, our friends that I haven't seen for a long time. And thanks to EHC and EuroBloodNet, and thanks to you.
Thank you for being in the scientific committee, for helping us to form this program, and thank you for a fantastic webinar. Thank you everyone for attending. For the patients present here, I want to stress that we have a WhatsApp support group because we know how difficult it is for patients, and sometimes they feel very much alone. So if you want to be included in that support group to get more information from the patient community, please get in touch with the committee at the mail which was in the chat, which is vwd@ehc.eu. And we will take care of you. For others, please visit ERN website. There are plenty of materials available. Also, ERN provides support for second opinion for patients, and some other things which are very unique. And again, thank you everyone for attending, and thanks so much. And we really, as a patient community, we want to thank the ERN for such a great opportunity, because it's really rare that we have clinicians, we have patients together discussing such topics. Thank you so much, and we hope to see you next month at our webinar. Thank you.
Thank you. Bye.
Hi, thank you all.
Bye.